absolute pleasure to extend a very warm and sincere welcome to all of you, to our esteemed faculty, our brilliant speakers, our dedicated sponsors, and of course to every fellow radiologist who have joined us today. Welcome to Day 3 of SOIICON 2025. It is my honor to be your Master of Ceremonies for the day. I hope everyone enjoyed yesterday's gala dinner. Today, we are gathered here to dive deeper into oncoimaging. Over the next few hours, you will hear from some of the brightest minds in the field. Their insights, research, and clinical experience will undoubtedly be inspiring. And at the end of the day, we have the awaited valedictory function where we will reflect upon our learnings, recognize the deserved, celebrate the success of this event, and express our heartfelt gratitude to all those who made it possible. As we have a packed and exciting schedule ahead, let's get going. To begin the first session of the day, Head and Neck, it is my great privilege to welcome our esteemed chairpersons for this session, Dr. Sandeep Bhuta, Professor Neuroradiology, Director of Research, Griffith University, Dr. Nadeshan Chidambaram, Head of Radiology, Apollo Hospitals, Chennai, and Dr. Prabhu, Consultant Surgeon, Head and Neck Surgery and Oncology, KMCH. Please join me in giving them a warm welcome. We will begin our day by going back to the basics, important landmarks in head and neck cancer, clinical anatomy by Dr. Nivedita Chakrabarti. Let's welcome her on the stage with a warm round of applause.
Good morning, everyone. I would like to thank the organizers for inviting me as a faculty in this wonderful conference. So I'll be speaking on important anatomical landmarks in head and neck cancer from the clinical perspective. So I'll be covering only the crucial structures which are important from the management point of view at each of these head neck subsites. So let's begin with the larynx. So you all know that larynx extends from the tip of epiglottis till the lower margin of the cricoid cartilage, and it has three subsides: supraglottis, glottis, and subglottis. So the supraglottis extends from the tip of epiglottis till the laryngeal ventricle. What is this laryngeal ventricle? It is a space which is bounded above by the mucosal folds of the false cord and below by the thyroarytenoid muscle of the true vocal cord. The craniocaudal extent of this laryngeal ventricle is exactly matching with that of the height of the arytenoid cartilage. So the tip of the apex of the arytenoid cartilage is a part of the false cord, and the base of the arytenoid cartilage, you can see over here this arytenoid cartilage, the base is a part of the true vocal cord. So if we draw one arbitrary plane 1 centimeter below this laryngeal ventricle over here, that will comprise the glottis. And from the lower margin of the thyroarytenoid muscle, that is lower margin of the true vocal cord, till the lower margin of this cricoid cartilage is the subglottis. So now let's look at the supraglottis. So supraglottis comprises of, this is the epiglottis over here, the median glossoepiglottic fold, the aryepiglottic fold, the pre-epiglottic fat space, and the paraglottic fat space, and the laryngeal ventricle. They are all a part of the supraglottis. Now this pre-epiglottic fat space is best visualized on the sagittal reconstructed image. You can see on CT, this is the fat containing pre-epiglottic space. On T2, you can see this bright fat containing space. This is the pre-epiglottic fat space. Now involvement of pre-epiglottic fat indicates metastatic nodal involvement, and therefore single treatment or single modality management is not sufficient. With radiotherapy, a chemotherapy is essential to be given if this pre-epiglottic fat space is involved, as it entails nodal involvement. Now, remember one thing, the mucosa of the larynx is continuous with the oral cavity and oropharyngeal mucosal space, and below it is continuous with the tracheal mucosa. So this mucosal extent can be well visualized by the surgeons endoscopically. But the submucosal spread of the disease, they are completely blinded to, and we as radiologists play a role in providing the submucosal extent of the disease. Now coming to the epiglottis. So you can see superiorly the epiglottis is free. It has got an anterior lingual surface and posterior laryngeal surface. But the stem of epiglottis is attached via thyroepiglottic ligament to the thyroid cartilage at the anterior commissure. So, epiglottic cancers can spread inferiorly via the thyroepiglottic ligament to the anterior commissure, that is at the glottic level, and subsequently to the subglottis. Now remember one thing, aryepiglottic folds we have talked about is a part of the supraglottis. But remember, the posterior surface of the aryepiglottic fold forms the anterior margin of the pyriform sinus. Pyriform sinus is a part of the hypopharynx. The medial aspect of the aryepiglottic fold is a part of the larynx. So disease from the aryepiglottic fold can easily directly spread to this apex of the pyriform fossa. Now coming to the glottis. So how do we identify glottis? Firstly, there is absence of pre and paraglottic fat space. Secondly, all the three cartilages are seen at this level. So you have this thyroid cartilage, you can see on the CT, the vocal process of the base of the arytenoid cartilage and the cricoid cartilage. So all three cartilages are seen at the glottis level. So what are the parts of glottis? You have the anterior commissure over here. You have the paraglottic space at this level is occupied by the thyroarytenoid muscle. So you have this thyroarytenoid muscle over here and the posterior commissure. So what is anterior commissure? It is a point where the two thyroid lamina, they join anteriorly. And at this place, there is a Broyles ligament which connects the vocal ligament to the inner margin of the thyroid lamina at this place. And at the attachment of Broyles ligament at anterior commissure, the perichondrium of thyroid cartilage is dehiscent, which means if there is a disease involving the anterior commissure, it can get easily upstaged to either T3 if the inner cartilage is involved, or T4A if there is an extralaryngeal spread. So you can see over here, this is the area of anterior commissure. So more than 2 millimeters soft tissue thickness at this level is suspicious. Now, what is this vocal ligament that I was talking about? It is located medial to this is a thyroid muscle. Medially, you have the vocal ligament. It takes attachment to the vocal process of the arytenoid cartilage. Now, what is the posterior commissure? So, posterior commissure is located between the vocal processes of this arytenoid cartilages. Here, the mucosa you can see is closely adherent to the inner margin of the cricoid cartilage. So, even more than 1 millimeter soft tissue thickening at this place is suspicious. And if there is a disease involving the posterior commissure, it can track posteriorly. And what is this place over here? This is postcricoid area of the hypopharynx. So any disease from the posterior commissure can easily track behind into the postcricoid area of the hypopharynx. Now coming to subglottis. Even here you see the mucosa on the airway side of the subglottis is closely attached to the cricoid cartilage. So any amount of soft tissue on the airway side has to be viewed with suspicion. Okay. So now we've talked a lot about the types, the subsites. Now let's look at the cartilage. So why is there so much hue and cry about the cartilage involvement? So you can see if there's a paraglottic space involvement extending up to the inner lamina of the thyroid cartilage, or if there is a subtle erosion of the inner margin of the thyroid cartilage, the management remains the same. That is organ preservation with chemoradiotherapy. So, which also means that you have got a CT scan done and you are 100% sure that the outer margin of the thyroid lamina is not breached, it is intact. But if you have a doubt whether there is erosion of the inner lamina of the thyroid cartilage or not, then the management remains the same. So you need not go ahead and order an MRI for that. But if there is a through and through erosion of the inner as well as the outer margin of the thyroid cartilage, then organ preservation with chemoradiotherapy is no longer possible. The only treatment option remains is laryngectomy. So if you're unsure if the outer border is eroded or not, then please go ahead and order an MRI. That would give you a clearer picture. So if only inner margin of thyroid cartilage eroded or only the tumor extends up to paraglottic space, that is T3, the treatment remains chemoradiotherapy. If outer border is breached of the thyroid cartilage, then laryngectomy is the treatment of choice. Okay, now let's go to the oral cavity. So you are all aware that oral tongue is the anterior 2/3. Posterior 1/3 of the tongue is also known as base of tongue, and it is a part of the oropharynx. The staging is different. So the 4 extrinsic muscles of tongue, the genioglossus, the hyoglossus, the palatoglossus. Now palatoglossus forms the anterior margin of the tonsillar pillar. So it is a boundary between the oral cavity and the oropharynx. And you also have the styloglossus attaching and merging to the hyoglossus. Mylohyoid is not an extrinsic muscle of tongue. So you can see what are these structures? This is a geniohyoid. You can see on sagittal, this is a geniohyoid, on coronal, this one. This is a supporting structure to the floor of mouth. It does not form a part of the floor of mouth. It is a supporting structure. So now let's look at the floor of mouth. So surgically, floor of mouth comprises of the mucosa lining the inner wall of the mandible, the mylohyoid sling. You can see the 2 mylohyoid muscles over here, mylohyoid sling, and the sublingual space. So surgically, sublingual space is a part of the floor of mouth. Now, this is the sublingual space. So this mylohyoid muscle divides this submandibular and the sublingual space. So superomedially you have the sublingual space and superolaterally the submandibular space. Now the posterior part of the sublingual space over here is divided by the anterior fibers of the hyoglossus muscle into medial and lateral compartments. So medially you have the lingual artery and vein and the glossopharyngeal nerve. Laterally, lateral to the hyoglossus, you have the hypoglossal nerve and the lingual nerve. So geniohyoid, remember, is not a part of the floor of mouth. It's a supporting structure. Okay. So now you have, these are the neurovascular bundles. As we have seen, the sublingual space houses the neurovascular bundle. And remember, either abutment or encasement of these neurovascular bundles indicate presence of perineural invasion on postoperative histopathology, and perineural invasion is a negative or a poor prognostic marker. Therefore, if you see abutment or encasement of these neurovascular bundles, you are supposed to mention that on the report. Now coming to retromolar trigone. So what is a retromolar trigone? It has an apex and a base. So the base of the retromolar trigone is posterior to the lower last molar, and the apex is located posterior to the upper last molar. Now why is this important to mention whether a retromolar trigone is involved by the disease or not? So firstly, from retromolar trigone, the disease can easily spread to the mandible and cause erosion, and thereafter to the mandibular canal and the inferior alveolar nerve. Also, medial to this retromolar trigone, this ligamentous structure which you see is the pterygomandibular raphe. So this pterygomandibular raphe takes attachment from the medial pterygoid plate superiorly. So from here, from retromolar trigone, the disease can easily spread to the medial pterygoid plate and upstage the disease. Next, this is a superior pharyngeal constrictor muscle, which you can see over here, this thin lining, and it attaches to the posterior margin of this pterygomandibular raphe over here. So from retromolar trigone, it can easily spread to the oropharynx as well. And you can see anteriorly, this is the buccinator muscle which attaches to this pterygomandibular raphe. So because from retromolar trigone, the disease can spread to the mandible, to the medial pterygoid plate, oropharynx, and therefore it is crucial to mention if the disease is involving this structure. So many a times the surgeons, even though there is no erosion of the mandible, they think of considering segmental mandibulectomy in such scenario to get a wider resection margin and so that there is no recurrence. Now, what is infratemporal fossa, temporal fossa, and masticator space, and why are they important? So any part of the masticator space above the zygoma, above the zygomatic arch, is a part of temporal fossa, and below the zygomatic arch you have infratemporal fossa and masticator space. Now infratemporal fossa extends from the inner margin of this ramus to the pharyngeal mucosal space, and it includes the parapharyngeal space, which means that the masseter muscle is not a part of the infratemporal fossa. That is the difference between ITF and the masticator space. So you can see masticator space, obviously masseter and the muscles of mastication. Now, what is high and low ITF? We mention a lot about this in the report, and what are its significance. So this is a sigmoid notch you can see in the inset of the mandible. So all the parts of the ITF, or infratemporal fossa, above the sigmoid notch is a part of the high infratemporal fossa. Anything below is a part of the low infratemporal fossa. Now on axial images, can you say whether it's a part of high or a low ITF? You can. If this ramus is single, you can say this is a single bony structure. This is a low ITF level. Now if this divides into coronoid and condyloid process, which means you see two bony structures over here, then it is at the high infratemporal fossa level. Okay, so let's look at so that means the medial pterygoid muscle is a part of low ITF and lateral pterygoid muscle is a part of high ITF. Now what is the significance of low and high ITF? Remember, high ITF involvement by tumor by itself is a poor prognostic factor. But even within the high ITF, if only the anterior retroantral space of high ITF is involved, then it has a relatively better prognosis compared to rest of the high ITF structures. So many a times, if only the retroantral space at high ITF level is involved, the surgeons might upfront operate it or give a neoadjuvant chemotherapy. But if this posteromedially, these structures are involved, pterygopalatine fossa, lateral pterygoid muscle, it's obviously inoperable. So you need to mention not only where the high ITF is involved, but where in the high ITF the disease is located. So now a bit about mandible. You know, this is mental foramen which continues as mandibular canal, and then you have the mandibular foramen over here. So any disease, you can see over here that this left side inferior alveolar nerve is thickened and there is loss of fat surrounding it in the mandibular foramen. You always should compare it with the contralateral side. That's the beauty of head and neck. You can compare it with the opposite side. So you can see this nerve is thinned out and there is fat in the mandibular foramen over here, but this is thickened. But only mentioning that there is a perineural spread is not enough. You have to give the extent of perineural spread. So what all you should comment on? How much is the perineural spread from this structure? What is this? This is a foramen ovale. So how much? What is the craniocaudal length of the perineural spread from foramen ovale? This is on the coronal CT. This is the location of foramen ovale, and this is on T1 MRI. So you have to give the distance. Now what is marginal and segmental mandibulectomy? These concepts are important. So in marginal mandibulectomy, only the superior rim of the mandible is removed and the continuity of mandible is intact. Mandibular canal is not touched. Whereas in segmental mandibulectomy, a segment of the mandible is resected out. So there is discontinuity in the mandible. So you also have to give in your report what is the height of mandible free of erosion or free of paramandibular soft tissue, whichever is less. So at least 15 millimeter height of intact mandible should be present to go ahead with only a marginal mandibulectomy. Otherwise, a segmental mandibulectomy is warranted. Now look at this case over here. The entire height of mandible is occupied by paramandibular soft tissue, but there is no erosion. Still, you have to mention in the report the height of mandible free of paramandibular soft tissue is 0. Okay, so I said whichever is lesser, either free of erosion or free of paramandibular soft tissue. So surgeons will need to go ahead with segmental mandibulectomy. Okay, next is about hyoid bone. So if a disease infiltrates the hyoid bone, then it is inoperable. But you also have to mention if a disease is located and is extending within 5 millimeter of hyoid bone, because surgeons need to have a margin of at least 5 millimeter from the hyoid bone. So many a times you will see the tongue cancers, they extend along particularly hyoglossus muscle. They would be tracking and extending to this hyoid bone. So you need to document this if it is within 5 millimeter. If you see this kind of a scenario, the surgeons will not upfront operate it. They will think of giving a neoadjuvant chemotherapy with the aim of getting a resection margin post NACT. So you also have to comment on this. Now coming to oropharynx. So early T1, T2 oropharyngeal cancers, sometimes the surgeons can consider TORS, that is transoral robotic surgery. So what is a prerequisite? It should be T1, T2 and the superior pharyngeal constrictor muscle. This is the superior pharyngeal constrictor muscle. This should be intact. Because if this is breached and goes into the parapharyngeal space, then it is not amenable to TORS. So if you find early oropharyngeal cancers, do comment on the superior pharyngeal constrictor muscle if this is seen, this is intact or not. Then, can anybody identify a vascular variation over here, which is crucial for, commenting upon the T1, T2 oropharyngeal cancers, if it's eligible for TORS? Okay, this is an arrow. Anybody? What is this? This is ICA. This is a location, retropharyngeal ICA. So it is important that you comment upon whether there is a retropharyngeal ICA, because if this is present, then it becomes a contraindication to operate in case of TORS. Now a bit above pterygopalatine fossa, you know the connections you should know, because it's the most important way of spread, perineural spread. So laterally it opens via pterygopalatine fissure into the ITF. Inferiorly, this is the Vidian canal. Anteriorly, the infraorbital fissure. And superiorly, this is the foramen rotundum opening into the middle cranial fossa. So remember, on core, the superolateral foramen is the foramen rotundum. Inferior one is the Vidian canal. And always comment on MRI on T1 non-contrast MRI image. Perineural spread should be commented upon. So because the fat effacement is easily seen on T1 non-contrast image. So T1 non-fat sat image should be used for commenting upon the perineural spread. And after you see a perineural spread over here, if there is subtle effacement of fat, then you go ahead with the contrast images. So non-fat sat T1 should be the sequence. And just one slide about nasopharynx. So you know anteriorly there is eustachian tube opening over here. This is the torus tuberous, which is the mucosal bulge surrounding the eustachian tube cartilage. Posteriorly you have the fossa of Rosenmuller. So this is the levator veli palatini, and this is laterally the tensor veli palatini. Any involvement of tensor veli palatini will lead to eustachian tube dysfunction, and effacement of the this eustachian tube orifice will lead to middle ear effusion. So elderly patient with a unilateral middle ear effusion, you should be cautious and look for nasopharyngeal carcinoma. You can see over here on the right side, the eustachian tube orifice is effaced. The tumor is extending contralaterally, but the left side eustachian tube orifice is patent. So you can see unilaterally you have a middle ear effusion. Thank you. I think bang on time. Any question? Okay.
Thank you, ma'am, for that comprehensive presentation and clear explanations. It took us all right back to our first year anatomy dissection hall. Thank you once again for sharing your valuable time and knowledge with us today. Next up, I'm delighted to invite on stage Dr. Pankaj Sharma, Additional Professor of Radiology, AIIMS Rishikesh, to deliver his take on surgical resectability in oral cavity malignancies. Sir.
First of all, I would like to thank the organizing committee for giving me this opportunity. And next 20 minutes or so, I will be talking about surgical resectability in oral cavity malignancy, landmarks and limitation. And my work has been made easy by Nivita, who beautifully told about the anatomical landmarks. And so I will skip this because already Nivedita has covered in detail the relevant anatomy. So to briefly outline, if we talk about oral cavity, this is the area which is the area of vestibule, and this is the area of vestibule, and this is the oral cavity proper. So Nivedita talk about a retromolar trigone. It's a triangular shaped mucosal fold with base behind the last mandibular molar and extends superiorly behind the with the apex behind the upper last molar. So this is the retromolar trigone which is shown here. If we talk about buccal mucosa, it is lateral to the vestibule buccal mucosa, and it's actually not a part of the oral cavity proper per se, but it's an important area of disease spread in gingivobuccal sulcus malignancy. So this is the area of the buccal mucosa, buccal space, and this is the buccal mucosa. So this is important when we talk about gingivobuccal space malignancy, because this is an important landmark through which it can spread. Then Nivita already told about infratemporal fossa and masticator space, and how that masseter is not a part of the infratemporal fossa. And she beautifully told how can we demarcate these spaces when what about importance of middle pterygoid muscle and middle pterygoid plate involvement when we talk about infratemporal fossa and masticator space. Then a word about supranotch and infratemporal fossa. So if we talk about infratemporal fossa, it's divided into the supranotch and infranotch segment by line passing through the this sigmoid notch. And Nivita clearly told you, if you see one part of the mandible, then it's a notch infratemporal fossa. And if you see these two parts, then it's a supra, because this is the most important landmark when we talk about surgical resectability, and I will talk about this in further. And Nivida rightly told that if it's a supranotch disease, then not only telling that it's a supranotch disease is helpful. We have to further test whether it's limited to anterior part, whether the retroenteral fat is only involved or other parts involved, because the surgical resectability changes. Some surgeons operate if it's only limited to the retroenteral fat space only. Some give neoadjuvant therapy and then do the surgical resection. So if we talk about AGC 8th edition, there were 3 important additions to this, the changes as compared to 7th edition. First was addition of depth of invasion to T criteria. And instead of earlier we were using tumor thickness as the criteria. But in 8th AGC, there was a change of depth of invasion, and we have already published on that ultrasound is a very good modality for assessing the depth of invasion, specifically in early stages. So if we talk about tumor thickness and depth of invasion, what is the difference? If it's a proliferative disease, what we do is, for measuring the depth of invasion, we join an artificial line from a normal mucosa to normal mucosa, this side, and from this point we measure the maximum depth of the invasion. So this is depth of invasion. Whereas for tumor thickness, we measure from the most protruding part to the deepest point. So if it's a proliferative lesion, then depth of invasion is less than the tumor thickness. Whereas if it's an ulcerative lesion, in this ulcerative lesion, our depth of invasion will be from this artificial line to the maximum depth. So here, and whereas the tumor thickness will be this part. So in an ulcerative lesion, the tumor thickness will be less than the depth of invasion. This is important concept when we talk about 8th AGCC classification, because we no longer talk about tumor thickness when we report. And why this is important? Because multiple publications are proved, and even in our publication we amply clarified that if the depth of invasion is 5 mm or more, then surgical neck dissection needs to be done. If depth of invasion is less than 5 mm, then if the neck region is normal, not look normal, then surgical neck dissection can be avoided. Second is the removal of extrinsic muscle invasion for T4A disease in 8th AGCC. And third is the inclusion of extranodal extension in N criteria. So if we talk about T stage, then important is when we have to call it as T4A and when we have to call it T4B, because the surgical resectability changes. If we talk about T4A moderately advanced disease, there is invasion of the bone, maxillary sinus, extrinsic tongue muscles, skin of face, or lip tumor involving anterior alveolar nerve or floor mouth, or tumor with bilateral tongue involvement or depth invasion more than 20 mm. So if the depth of invasion is more than 20 mm in tongue with bilateral involvement, then it's straight away T4A. When do we call this T4B? When it's an advanced disease. When there is invasion of masticator space, when there is invasion of pterygoid place, there is invasion of skull base or ICA encasement. So if there is a masticator space invasion, pterygoid plate invasion, there is skull base invasion, or there is encasement of ICA, then it's an advanced disease. Then if we look into the end staging, you can very well see in this AGCC, we talk about ENE. Because the staging, it's a N2A if it's a ipsilateral single lymph node 3 to 6 centimeter with no ENE. However, if it's a ENE, then straight away it goes to N3A. So staging, your end staging changes soon you talk about ANE, then it's a N3B. And N3A lymph node size is more than 6, but no ENE. Whereas N3B, there is any size lymph node with clinically overt ENE. So as soon as you say it is ENE is present, it stays straight away 3B. And there's no change in M staging as when compared 7th to 8th edition. So depth of invasion, tumor thickness is, I've already told what the difference between both. And CT and MRI have limited role in evaluation of depth of invasion, and high frequency ultrasound has now been amply clarified, specifically with the use of hockey stick probe, where you can accurately measure the depth of invasion. And depth of invasion is measured as histological tumor infiltration below basement membrane, which is equivalent to the endophytic component. There is, I have told, and so whenever we are assessing tongue, if we can do intraoral ultrasound, only limitation is if the patient has limited mouth opening and we can not insert our hockey stick probe. That's the only limitation when we are not able to do the intraoral ultrasound. So this is showing us the depth of invasion assessment when we talk for tongue invasion or gingivobuccal. For gingivobuccal, we'll draw this line and we measure the maximum depth of invasion. Similarly, for tongue, we measure the thing. So if we talk about ENE, perinodal fat standing and infiltration into the adjacent fat or muscle have high specificity for predicting ENE. And the indirect signs of ENER is especially in a high level 2 node include denervation atrophy or signs of dysfunction of muscle innervated by the upper cranial nerves 9 to 12. Second, in addition to imaging evidence of ENE, the AGCC staging system also requires the presence of clinical findings of gross ENE for a patient to be upstaged based on ENE. So if you talk about, it's not only imaging, the AGC system also requires the presence of clinical findings of gross ENE for patient to be, and as soon as you labeled it as ENE is present, straight away is N3B. So this is important when you when reporting. And this is our CT and MRI depicting the externodal extension, and we have to report this as Nivedita has rightly told. If we talk about gingivobuccal and retomolar triangle malignancy, these account for almost 10% of oral cancers, and these are the third most common type of head and neck squamous cell carcinoma in the South Central Asia, and these are commonly referred to Asian oral cancers. And gingivobuccal sulcus and retomolar triangle cancer have high invasion, high incidence of bone invasion involvement, with direct impact of surgical planning. And contrast enhanced MDCT post technique is the imaging modality of choice with high specificity. And we have recently published that in a resource constraint setting, CT can very well be used for seeing for your perineural spread and commenting about the extension of the oral malignancy. MRI has high specificity and negative predictive value, however low specificity in detecting cortical invasion, which makes it an inferior imaging tool for gingivobuccal sulcus and retomolar triangle malignancy. And contrast NS MRI can be used as a problem solving imaging modality for suspected perineural spread beyond mandibular foramen and the intracranial extension. So this is case in MRI where we are measuring the depth of invasion, and in this case it is 6.5 mm. So this was T2 stage, and here it first image was 4.6 mm. So it's a T1 stage. So if the depth of invasion in if we talk about tongue, if it's less than 5 mm and neck node is looking normal, then the neck dissection can be avoided. And this is T3 stage where depth of invasion is more than 10 mm, and the T4 stage where it is extended to the overlying skin. And this is T4B stage where the masticator space is involved. So if we talk about cortical erosion, in this case first, there is only superficial cortical erosion in gingivobuccal sulcus melanosi, whereas here we are seeing the deep cortical invasion. So, a word about perineural spread in gingivobuccal sulcal melanosi predominantly occurs along the mandibular nerve, further along the parapharyngeal space to skull base and foramen oval, and Nivedita has covered this very well. On CT, when do you say it's a perineural spread? If there is more than 1 millimeter asymmetry with the contralateral foramen, if there is loss of normal fat density in the foramen and abnormal enhancement with the foramen. In our publication also we have shown that CT is able to pick, but at a later stage, because this loss of this asymmetry, this loss of normal fat density and abnormal enhancement are picked at a slightly later stage as compared to the MRI. On contrast, in SMRI, we can do early detection of perineural spread. We can have exaggerated enhancement. We can have enlargement of the preceding nerve. And Nivedita already told that you only telling perineural spread is not enough. You have to tell what extent it is involved, because that helps in surgical management decision. However, MRI is shown to overestimate inferior alveolar nerve invasion due to the surrounding inflammation. So we should know the limitations of CT and MRI, where we excel and where it's help. So this is perineural spread along the skull base and extending into the foramen oval. So if we talk about management and surgical resectability, all gingivobuccal sulcus and retromolar triangular malignancy until stage 4A or T4A are potentially resectable. When you call it unresectable T4 disease, when it's a high in infratemporal fossa supranos disease, it's a relative contraindication to surgery. If there is high and posterior infratemporal fossa disease, involvement of pterygopalatine fossa, pterygomandibular fissure, and later pterygoid plate. And if it's a low infratemporal infranos disease with paraneural spread. So when we are reporting, we have to take care of whether these spaces, and if we follow a reporting template where we talk about these particular structures, then the work for the treating surgeon becomes easier. So I don't have much time, but I will say that infratemporal fossa, if it's a low, it's a resectable and upfront surgery is done. If it's a high infratemporal fossa, it's a relative contraindication to surgery, and upfront surgery vis-a-vis induction chemotherapy is what is followed. Reassessment is done followed by surgery vis-a-vis palliative chemoradiotherapy. If it's a high infratemporal fossa involvement, whether it's an anterior retroenteral fat only involved, then it's resectable and upfront surgery is done. If it's a posterior PPF and PFF involvement, then in unresectable due to high recurrence rate and palliative management is what is done. If it's a bone erosion, if there's no superficial cortical erosion, then T stage is not altered and depends on depth of invasion. And mandible preserving vis-a-vis marginal mandibulectomy is done. If it's a deep cortical invasion or medullary invasion, then it is straight away up stage to T4A, and segmental mandibulectomy is done. And Nivedita has very well covered what are the important landmarks we have to see when we decide about segmental mandibulectomy or marginal mandibulectomy. And if we talk about perineural spread, if it's a supranos disease, it's a resectable. Surgery depends on the soft tissue extent, which Nivedita covered, and infranos, it's unresectable, and palliative treatment is what is done. So I will not talk about much about this slide. I will straight go to next slide. If we talk about tongue and floor of mouth malignancy, these are most frequently occurring amongst all cancers. 75% arise in the anterior 2/3 of tongue, and this is the area where your high frequency ultrasound with the hockey stick probe is very good. Incidence is higher in developed countries and rising incidence in developing countries, all attributed to in our country due to tobacco ingestion in various forms in Western population due to HPV infections. And contrast in MRI is the modality of choice for tongue malignancy due to superior soft tissue contrast capability. Involvement, we can assess neurovascular bundle involvement, some lingual and some mandibular space involvement, and floor of mouth involvement. assessment of soft tissue extension, tumor thickness, peritoneal spread, and marrow invasion and nodal involvement, and involvement of genioglossus, hyoglossus, myeloid, and geniohyoid muscle. And tumor has intermediate to high signal intensity on T2 weighted and stir images. So in the interest of time, I will skip this slide. And for mandibular invasion, MR has low specificity. Cortical erosion is best assessed on CT, and MR can be used for assessment of marrow involvement. And depth of invasion, I've already covered that it predicts a risk for nodal metastasis. If it's more than 5 mm, then even though the neck lymph nodes will be looking normal, then also surgeons goes for neck dissection. And measurement of the depth of invasion should be always done on contrast enhanced T1 weighted images. You don't measure depth of invasion on T2 weighted or stir images, as it may lead to overestimation due to perilesional edema. And now a lot of literature has shown that exact extent of depth of invasion on tongue is better characterized on high frequency ultrasound if an early stage as compared to MRI, because in some cases you also take into account the perilesional edema when you do assessment or MRI as compared to ultrasound. So I will skip this slide. These are showing different stages of for assessment. And if we talk about management and surgical resectability, then what is unresectable disease? If it's a disease extension posteriorly into the tonsil, into the lateral pharyngeal bone and posterior-inferiorly to vallicula in the pre-epiglottic space, then it's an unresectable disease. If it's invasion into masticator space, then it's an unresectable disease. What is potentially resectable with morbid outcomes? Involving or in close proximity to hyoid bones less than 5 mm. Nivedita has already covered this part also. If there is a neovascular bundle involvement, and chemoradiation is preferred if surgery leads to poor outcome in these cases. So if what are the important imaging and management implications in tongue malignancy? If the tumor thickness is more than 4 mm or depth of, actually we don't talk about tumor thickness now, we talk about depth of invasion is what we should be reporting. If a depth of invasion is greater than 10 mm, it's a poor prognosticator marker and we consider for adjuvant treatment. If it's a spread across midline lingular raphe, then there's a high incidence of contralateral nodal metastasis and contralateral neck dissection and radiation needs to be done. If it's involvement of bilateral neurovascular bundle, it's extensive disease and total glossectomy, morbid surgery with flap reconstruction is done, depends on surgeon to surgeon. Then invasion limited to extensing muscles versus invasion of the floor of mouth. It's a resectable small volume disease versus a large volume disease. And reconstruction with free radical artery foramen flap versus reconstruction with anterolateral thigh flap or pectoralis major myocutaneous flap is what is practiced. If it's a posterior extension to vallicula, pre-epiglottic space and hyoid, it's an advanced disease and it's a relative contraindication for surgery. And primarily, it's the management is primarily non-surgical treatment. If it's a bone erosion, midline versus lateral, midline involvement needs a resection of the genial tubercle, which will lead to loss of tongue and laryngeal muscle attachment. And mid-third mandibulectomy with reconstruction needs to be. If it's extension to masticator space, it's a very advanced disease and palliative non-surgical treatment. So, and neck node involvement impact statement, I will just take 30 more seconds. Neck nodal metastasis has direct impact on treatment. Solitary lymph node involvement reduce survival to 50%. Additional contralateral lymph node involvement reduce survival to 33%. And role of imaging in detecting the occult metastasis, confirm nodal metastasis, measure the nodal burden, identify extranodal extension and carotid artery encasement in CN1 plus neck. And what are features of nodal metastasis? If there is nodal necrosis, it is the most reliable indicator with specificity 95 to 100%. If there is loss of fatty hilum, round appearance, cystic changes, lymph node size is not a reliable marker. This is very important for residents. You don't give much importance to lymph node as compared to other radiological imaging features. If there is carotid artery encasement, it's an unresectable disease. And if there is extranodal extension, it's a poor outcome. And hence adjuvant therapy is what is recommended in these cases. So I have already covered and in the interest of time I will skip this slide and I will say that complex anatomy of oral cavity makes it a challenging area for radiologists, and knowledge of the anatomy with understanding for common routes of spread of cancer allows the radiologist to accurately determine extent and augment clinical findings to plan appropriate therapy. And we should be talking in terms of what oncologist speaks, then only will become an important part of the management for this oral malignancy. With this, I end my talk, and I apologize for extending for the 30 more seconds. Thank you.
What a detailed yet captivating session, sir. The way you broke down such a complex information was incredibly clear and made the material easy to comprehend. We thank you for sharing your expertise with us. Coming up next, we have a case-based discussion on imaging of pharyngeal cancers. We invite Dr. Jayaraj Govindraj, Senior Consultant Radiologist, Apollo Hospitals, Chennai, on stage. Sir.
Welcome, Jayaraj.
Good morning, everybody, and good morning, chairpersons. It is again a pleasure to be back here in Coimbatore and to address this particular session. And I must thank the organizers for doing a wonderful job. It's actually a fantastic place that they've arranged. Thanks to the organizers, Dr. Matthew Cherin, and also Venkatesh Kashi, who's been the driving force. So, thank you all. Now, my topic for today would be imaging of pharyngeal cancer, and I'm going to take you through a series of cases that would help us gather some kind of a direction on this. So, basically, all cancers today have to be dealt with in a multidisciplinary team, and we are part of it, come what may, and we must exercise the particular anatomy as well as the extent of disease, as well as the spread of disease, must all be determined only by imaging. And if you look at the surgical books or the radiation oncology books, they're full of stuff which is mostly images. So we are the master of images, and let's keep it that way. So when we come to a multidisciplinary team on pharyngeal cancers, the surgical oncologist would start thinking of surgical planning, and we had a fantastic discourse by Dr. Pankaj telling us about resectability and non-resectability. Well, there is a gray area, there is a twilight zone, and that is sometimes extended in some individuals who are fit for surgery, and thereby these particular criteria are broadly the guidelines that we have to follow. So the feasibility and extent of neck dissection is discussed, and we have a very strong role in it. And the best surgical approach, ideally the utopia of all surgeons, is to have a R0 tumor excision. So they aim for that. Well, if there is any doubts on that, they come to us. And let's go to the radiation therapy planning. Now that's less of a surgical approach, but quite comprehensive in the head and neck, because most of the head and neck cancers are viable to and be addressed by radiation planning. So we need to keep that in mind. We work hand in glove with them and plan the radiation therapy fields, ensure the adequate tumor ablation occurs, as well as the nodal spread that is involved in most of the head and neck cancers should also be included. So we have to have a good knowledge of the anatomy that is necessary for our kind of discussion. So we must also remember that there are organs at risk. Example, the spinal cord, the esophagus, and the trachea, and they all are subject to the radiation in the same field. And that's why the radiation oncologist today is now looking at fractionated doses and etc. etc. There's a lot of treatment planning going along with that. So we'll go along with that. Now, treatment monitoring is something very, very important for us. And post chemo, of course, it's systemic therapy when they are not fit for RT or for surgical planning. They give a kind of a palliative chemotherapy, or sometimes it's curative in some instances, which my cases will tell you. So coming to the treatment monitoring response has become a big time work for the radiologist, especially in oncoradiology. And you have so many articles that have come out about treatment response in various cases that have been treated by the oncologist. So it's a very important part of our work. And to detect any signs of recurrence or residual disease is something that everybody wishes to know. So let's go on to the first case. Here's a 34-year-old lady who had nasal bleeds with ear block on and off since March 2025. And these are some of the images that give you an idea where the particular, can I have the pointer or should I convert this? Pointer. So already they are self-explanatory, and I'm just going to go through these images with you, and you see there's a lesion in the nasopharynx which is extending along the pterygopalatine fissure into the crevices of the base of skull over there. And this DWI is one of the most important imagings that we ought to have, because it gives you the cellularity equals the aggressiveness of the tumor, and it is coupled with the ADC and DWI match. You cannot have both showing similar kind of high intense values. So if you see, the areas that are bright here should be dark here. So it's a very basic thing that everybody follows. I'm just reiterating that. In T1 weighted contrast, the T1 weighted images are supposed to be the best for anatomy. And so thereby, when we add contrast to it, the areas that enhance by contrast will tell you the exact delineation of the tumor, just like my predecessor told you. Don't rely on the T2 or any other imaging, but rely on the T1 pre and the post contrast to take all your answers. So here's a set of examples where the same case, you can see that the base of skull is completely looked at. Only thing that you have to keep in mind is, if there is a phase out of the particular interface between the bone and the soft tissue, beware, there may be a bone infiltration which is best brought out by CT. So we have a load of armamentarium with us, CT, MR, as well as now the PET CT, which gives us the functional imaging too. So coupled with all that, we should be able to give a good precise idea about how the tumor and its aggressiveness and how it would respond. The prognostication is also another particular part of our work. Here's the example again to show you that the T1 weighted contrast imaging is so important to define the actual tumor. And you can see that this case has gone through the base of skull and also trying to include into the sinuses. So that's the importance of the nasopharynx, which is a common area of the aerodigestive tract. It starts there. Then go into the next case, which is a 55-year-old lady with again a nasal block, nasal bleed since 5 months with mouth breathing. So what happens? The entire upper aerodigestive tract is occluded, and here are the images that show you that the lesion is extending along the pharyngeal wall. Now that's very important. The local extent, local spread, lymphatic spread, and then of course the remote spread, which I'll come to later. So it's important to see the local extent of the disease very clearly, define it very well, and then the treatment options can be then discussed. Over here, we see that the lesion is also extending towards the hypoglossal foramen, but it's not entering that, even though there are various ways, and so we have to keep a watch on that, particularly implying a neurovascular bundle involvement or going along the neural tracts. The same case, a little more extended of our thing, to look for the nodes, and here you are, there are some nodal diseases also associated with it. These have to be marked, and these have to be staged as per the TNM classifications, and thereby is a role for nasopharyngeal carcinomas. In this instance, when we had nodal disease, know that there is extranodal extension, it's better to go in for a PET CT. And why? The PET CT will give you an answer not only about the local disease. Most of the time, it's a whole body PET CT. If you ask my nuclear medicine physician, he will also say, we are injecting the isotope anyway. Why do you have to do local PETs? They try to avoid it. When you inject and get the information of the whole body, it's the whole body PET CT that's important. And today, in head and neck cancers, we are seeing remote metastasis in the liver, in the lymph nodes, in the abdomen, and in soft tissue. So there you are. The PET CT strikes a note. It says be cautious. When you have ENE, when you have a larger tumor, more than T3, T4, then you just have to go in for a PET CT, and it'll give you all the answers that you have to tell for the patient well-being and the future treatment. So here we are. So this is how we describe that, and the aggressiveness of the tumor can be related to what is known as the SUV. And of course, all of you are aware of that the SUV is started with the Hodgkin's lymphoma, where the SUV was directly related to the aggressiveness and the tumor response was graded as per the SUV. But over here, In nasopharyngeal carcinoma, it's not always so. We have to keep that as an additional imaging modality for us to give the opinions for prognosis and treatment thing. So this was a case of nasopharyngeal carcinoma. So here's the thing that I'm going to extend a bit of my study and how we work closely with the radiation oncologists, as we call them. Here's a case that is in the lateral pharyngeal wall, nasopharynx, and then you see there are extensive bilateral nodal disease. In nasopharyngeal carcinomas, please remember that it crosses the midline, then you have to look at both the nodal stations on both sides of the neck. It's very, very important. And here you have huge nodes. And so, straight off they go for radiotherapy, because chemotherapy is supposed to be the one that is usually discussed in the MDT, and then with chemoradiotherapy, these lesions often just come and melt away. And when we see that, these are the important parameters that you got to know: the gross tumor volume, the clinical target volume, the internal tumor volume, and when you plan for the tumor volume, you have to know these regions, and that's how the treatment planning happens. Get familiar with it. Get to know it, and if you are part of the MDT, it's going to be a very useful thing that you have to keep in mind. So when you go on further, see the response. 3 months post CT-RT assessment, there is no activity again, but the bulk of the tumor is there. Now you start thinking, is it radiation, post-radiation thing? But importantly, you're not seeing any active lesions, so you can follow it up. So the CT-based definition of lymph nodes in head and neck must be kept in mind. The various spaces and the must be clearly mentioned. 1A, 1B, 2, like that it goes on. And this is how the entire neck should be covered in your reports. So a word about organs at risk. Over here, when you do the neck, the primary organ at risk is the spinal cord. And so the radiation fields are always arranged in such a way that it avoids the spinal cord and gives much, much less dose to the spinal cord, and thereby you have a method of treatment here. So people start asking about proton. What is IMRT? Intensity modulated radiotherapy versus proton therapy. Now in proton, one of the major advantages is the field of energy that goes, hits the target and stops short by millimeters at the margin of what you have drawn. So that way we play a very strong role in the proton therapy units. It's important that we should know the tumor, the actual size and extent for us to give the best results. So it's very important. When you look at it, it's a more conformal dose, that's how they call it, and its distribution is better, sparing the normal structures, and thereby the organs at risk are much less at risk with proton. And also in cases that are recurrent, there you have problem, then you can go in for proton, which is a higher energy and much more efficient. So people tend to go towards proton. It's expensive now, but soon I think will become available a lot of places. Now, going on to the next case, which I'd like to show, is a 45-year-old person, male, was being treated since 2017 for a diffuse large B-cell lymphoma. And he started complaining of nasal block with mouth breathing. And then here you are. There's the culprit. That's the mass in the nasopharynx. And then look at the lesion spread out across the midline, and it's very bulky. It has homogeneous enhancement. On contrast, that's the highlight. In other lesions like nasopharyngeal carcinoma, it will be a heterogeneous enhancement. In lymphoma, it will be a homogeneous enhancement, and the bulk of the tumor will be very visible. It will be kind of rounded. So just as you imagine lymphoid tissues burgeoning their way out, that's how it looks. So you can see the bulges. And this is how the lymphoma would appear. And this, in this case, it turned out to be that the lymph nodes in the left side at level 5A are also involved, and thereby on both sides, you can see on the other side too. So we have to have the laterality of the nodes, everything kept in mind, especially in NPC, and there you are. This is the PET CT that was done, and there was a relapse of the lymphoma, especially involving the Walde's ring. I hope you all remember the Walde's ring is a ring of lymphoid tissue in the region of the nasopharynx. It includes the tonsils also and the submucosal lymphoid tissue. Okay, we go on to the next case, and this person complained of ulcer in the mouth on the inner side of the cheek, and then here you are. I suppose we shouldn't be, especially in cancer treatment and all that, we must go for the best modality that gives you all the answers, be cost effective in your approach. And when we do so, it's very evident that MRI scores over everything. And here you have a case in which the lesion is involving, anybody tell me, guess? You look at the DWI images here, and you can see that there is an increase in the cellularity along the buccal mucosa. So this is a case of buccal carcinoma and buccal mucosal carcinoma, and you see the extent of the disease. It's coming up into the tonsillar area, and fortunately it's not involving the retromolar trigone, which is another dangerous area that we got to keep in mind. Let's go on to the next case. It's 47-year-old mass in the right cheek with a mouth ulcer on the inner side of the cheek since more than 8 months, and you see on this side, it's a gross tumor. And not only is it involving the alveoli, destroying the bone, but also extending it. This happened to be a squamous cell carcinoma, quite a cellular aggressive tumor. And you can see the aggressiveness on the DWI, and the other images will belie what the extent of the disease would be. So we go on to the next case, which is mass in the left side of the tongue since 2 months. The approach is that, as my predecessor already explained, for the tongue, MRI. So you have to know that you have to take it in 3 different planes to localize the tumor very well. And so we have axials, sagittals, and coronals that give you the extent of the disease, which should be pretty accurate. And I'm giving you the example of this particular lesion. You see the DWI, everything should match. The area of enhancement should match with the area of the increased signal intensity on the DWI, and thereby you have a very strong role to play in defining the size, local extent of the disease. We'll go on to the other side of the tongue, and most importantly, you must make sure that it doesn't cross the midline. Crossing the midline is something that you have to keep in mind, because not only does it go to the local nodes, the adenopathies in this case would be at level 1B, 1A, B, and at level 2, but it can also go down to the opposite side, level 4. So you have to look at all the nodal stations in such individuals and make sure that you get the case properly given the TNM classification. Here's another case of a 63-year-old gradual inability to open the mouth with trismus. Now what's happening? Whenever you hear the word trismus, get alert, because it means that the muscles of mastication that move the TM joint are involved. And when will they be involved? When that particular space is involved. And this is a classic case where the buccal lesion has gone through the TM RMT, as we call it, the retromolar trigone, which is a hotbed area where every space converges. The masticator space converges, the buccal space converges, the lingual, everything goes through in that particular route. And if it is involved, then all these routes are ready for spread of disease. So when we look at it in 3 different planes, we see that this particular lesion is quite extensive. The prognosis is also bad, and no surgeon will touch. So it has to go in for radiotherapy. So this is how the clarity of the T1 post-contrast images are so important in our panorama of workup of the cases. Let's go on to the next one. Here's another 60-year-old male with a history of a foreign body sensation in the throat, March 2025. And of course, here is he got a huge lesion. God only knows how he could bear this and swallow stuff, but still he did it. And there you see the aerodigestive tract is narrowed out, tonsillar fossa and beyond. It's going down into the hypopharynx also, so we have to give the particular TNM staging for it. What did they do? They went ahead with the radiotherapy, and when you see that the cellular lesion has lost its cellularity, that is the power of CTRT. The chemo as well as the radiotherapy that was given to this patient was very well taken just between a matter of 4 months. Now we have to hold it that way. That's the important thing. So follow-ups are also important. So there you are. You always go back to the old images and go work your way up to the treatment so that you get the right picture. So this case has got a very good response and is currently on follow-up. See, all the three planes must be utilized. And this is a squamous cell carcinoma, well differentiated. Going on to the next case, again, this is a case which is a little lower down, not so extensive, but again having the same serious import. So left tonsillar fossa extending into the lateral wall of the pharynx, as you can see there, very clearly determined, and again CT-RT was given for this patient. Now, yet another case, 48-year-old going further down. Over here, a lot of structures that you have to bear in mind, and that is the hyperpharynx, the cricoid, the pyriform sinus, everything is involved. So the extent of disease must be clearly identified, and then only you will get on to the treatment plan. So here's an example of a 41-year-old who had a hypopharynx, not so large. Another one. Do I have time? Just another 5 slides, or shall I stop here? I can go to the last slide. Chairperson. Okay. Right. Well, when you plan the CT before starting chemoradiation, this is the way it is done. This is the actual treatment volume that you have to outline. Believe me, that's important. And in the particular lab workstation that the radiotherapists have, they can fuse the MRI on the CT scan and then give you the best of the origins and the extent of the disease, and they often seek a help to get this thing done. So chemoradiation is preferred over surgery, especially when there is a need for larynx conservation, because he loses his voice otherwise. 5th week of chemoradiation showing partial response, and there you are. That's how it is. This 3 months later, the PET-CT images show complete response. A word of caution: post-radiation, there is an intense enhancement of the mucosa with uniform thickening of the mucosa extending throughout the radiation field. And this is how the PET images would look. So do not write it as recurrence, do not write it as residual disease. So the advances in cancer biology is immense. Now they've started looking at HPV in oral pharyngeal carcinomas. And it's important to know that if it is HPV positive, then there is a very good prognosis. So keep all this in mind, that most commonly it's squamous cell carcinoma. It can spread in all these ways, and then you have to know all these little intricacies of giving the treatment properly to the patient and getting the best results. So thank you very much for your attention.
Thank you. Thank you, Jairaj.
Thank you for a very practical approach to imaging in pharyngeal malignancy, sir. You have given us an expert perspective on how to approach such complex cases. Next, I would like to welcome Dr. Amit Janu, Consultant Radiologist, Tata Memorial Hospital, on stage for a talk on perineural spread in head and neck cancers. Sir.
I think Sir has already covered many aspects of head and neck imaging and some of the touching points on the perineural spread. So just going into the topic, we know that we have, because perineural spread, it spread along the nerves, we have to do thin multiplanar reconstructions both in the CT as well as MR, both in the bony window reconstructions and the soft tissue. And again, MR we have to acquire along the nerves if we are suspecting a perineural spread. So just to mention about the perineural tumor spread is basically an extension between the nerve and the sheath. But PNI is something which is you can often see in case of pathological reports when they just say there is an infiltration along the nerve. So these two are different entities, but most of the time they are synonymously used. CT is something which gives better information in terms of see the bony anatomy of the details, the kind of fat obliteration and widening of the foramen. Only if we have 1 millimeter thin sections, and that is in the multiplanar reconstructions. MR, T1 pre-contrast and post-contrast sequences do the better job. One is identifying the fat, second is identifying the enhancement. And these two are the important characteristics by which we identify the perineural spread. and then we have to cover the entire nerve from the origin to the nucleus. What is the extent of the nerve involved and till where exactly it is antegratally spread. If we talk about perineal tumor spread, we need to know that if the tumor size is large, the chances that it might have perineal tumor spread is high. If the depth of invasion increases, again there is a high chance of perineal tumor spread. If there is a poor differentiation or bad histology, again the chances are high, and if there is a higher nodal burden. But nevertheless, it can be seen in smaller section where we have to be more vigilant. If there is a already widespread disease, we are not worried about too much. But in a small disease where it looks like it to be surgically resectable and we are missing the perineural spread, the consequences are bad. So does all perineural, all histologies have perineural spread? No. So if we talk about, there are so many pathologies that are there into the skull base. There is a meningioma, chondrosarcomas, gliomas and other things. These are not associated with the perineural spread. The association is more commonly seen in carcinomas, and squamous we will see that it is most commonly, we will see, because that is the common histology that we will come across. And in these cases we have to be very careful. So in this particular case, there is an nasopharyngeal CA, and we can see that it is going into the bilateral parapharyngeal space, and through that it is taking the V3 and it is going to the cavernous sinus, and then there is a local spread as well in these areas. Again, in the follow-up, it has been reported that there is a residual disease, like sir has already mentioned. We need to very carefully see, these are just fibrotic changes. There is hardly any PET uptake in these areas. And again, it has been reported as in the follow-up that there is going to be recurrence after some time. And this is just, if we see on the CT scan, there is an osteoradio necrosis, another is the right temporal lobe necrosis, because the field that we have irradiated is very high. And if we see, there is no solid enhancement in these areas, it's just an patchy Swiss cheese kind of enhancement, and this is just the radiation changes. We need to know that there are specific areas where we see the anatomical details, what structures will cross through that, whether it is a vessel or the nerve. And if we label that this is going to be a nerve anatomy, then we know that we are hitting the perineural spread in that particular aspect. So we need to just careful about what are the things that are going through the various foramina, whether it is a foramen rotundum, foramen ovale, or spinosum, or Vidian canal, or pterygopalatine fossa, that I am not interested into that, but we should know that where exactly we have to look it. So this is the area where there is a hard palate, and then we can have greater and lesser palatine nerves. They can ascend and go into the pterygopalatine fossa. There is a medially, that is the sphenopalatine foramen, there is a pterygomaxillary fissure, and then more antegratally we can have the inferior orbital fissure and superior orbital fissure. So these are the things that we should be care about, and disease can take from any of these sites. So if we take about the V2, this is the, again, there is a hard palate lesion, and what we are actually seeing it, there is an enhancement, there is a widening of the greater and lesser palatine nerves, and then it is reaching till the pterygopalatine fossa. There is a widening, but we will not see the enhancement typically because these are the bone window settings. But if we see an MR, this is the hard palate lesion, and then there is taking the greater and the lesser palatine nerves, pterygopalatine fossa, and then there is a further antegrade spread. So this is the power of the perineural spread, that something which might be resectable on earlier CT scan, it looks very catastrophic on MR. Again, if we see, it is a lesion that is there into the upper alveolus, there is a perimaxillary soft tissue, and through that it is actually involving the infraorbital nerve, and actually then we can see that along the floor of the orbit, it is entirely going into the pterygopalatine fossa and then further antegradely into the cavernous sinus. So this is the power that even a small lesion like this can actually go far beyond till the nucleus of the nerve. Again, this is the case where there is an buccal CA, and if we see that it is involving the V3, and actually there is a fat that is we can see on the right side. These are the normal vessels, and this is the soft tissue that is extending into that particular aspect. And if you see, it is going till the nucleus of the nerve. It is very hypotense, very cellular tumor, and it is showing a strong enhancement on the CT itself. So if we are looking for the perineal spread, then we don't have to do only MRI brain, we have to see the entire anatomy of the nerve from the pathology, the primary site, till the nucleus of the nerve. So how will you identify? Typically, there is an asymmetrical thickening of the nerve. There could be asymmetrical enhancement, and we can have obliteration of the fat pad, and there is a widening of the foramen, and then there are secondary changes that can occur in this particular location. If we see the V3, again, we can see that there is a mental foramen here. Any disease near the V3 can take up this nerve and actually can reach the cavernous sinus. any disease which is in the floor of the mouth and lower gingival sulcus can take this nerve. Anything, if there is an alveolar disease, it can take the disease and can go along the mandibular nerve, and then subsequently it is going till the foramen. So we need to know how far it is extending. Sometimes if they are actually within the intraalveolar canal, then the composite resections are feasible, but it is going beyond the parapharyngeal space till the foramen ovale. Sometimes the resections are going to be difficult or may not be possible. So again, if we see that there is a buccal CA, and then we can see that it has taken the one of the tributaries of the nerve, and actually we can see that from the RMT, then there is a parapharyngeal. And how we'll identify? If we see the fat on the other side, it is very clearly seen. The fat here is dirty, and we can actually identify the various nerves, mandibular divisions, whether it is a masticator, lingual, and other things. And then we can see that there is some dirtiness, but the moment we will give contrast, everything is enhancing, there are denervation changes. And if we see the coronal, which is the crux of V3, identifying V3 perineal spread, it is going through the foramen ovale and going to the cavernous sinus. So we need to see that if there is a retroventral area which is having dirty on the CT scan, at least we should ask for an MR to rule out a perineural spread, which is sometimes difficult on the CT scan itself. Again, very small disease, the patient are having a lot of submucosal fibrosis, there is one finger mouth opening, and there is a small buccal CA. And if we see that this is near the mental foramen, and if we see this is the enhancement of the nerve along the V3, there is a contralateral side, we can see that the nerve, but this nerve is thickened and it is enhancing stronger than this. And if we can follow that, and actually we can see that it is going into the pterygopoetine fossa, and then along the VDN, and along the V3 also it is going and actually going to the cavernous sinus. So there are various interconnections that are happening in the parapharyngeal space, and it can involve multiple nerves and that particular site. Again, this is the nodal disease which is recurring, and we can see that there is a dehiscence, or we can see that there is erosion, and then here, from here it is taking the V3, and then actually subsequently it is going. And the pre-contrast T1 are equally important as compared to the post-contrast T1 to identify the nerves, and especially when the fat is very good in the parapharyngeal spaces. So we need to know that which is the probable nerve that is sitting near to the primary, and because that is the chance the nerve is likely to be involved, till where it is going, whether it is only in the intracanalicula, it is going to the parapharyngeal space, it is going to the foramen ovale, or it is going beyond that. And what are the sequences which we have to look? It is the pre-contrast T1 and the post-contrast T1. Again, here it is an high-grade parotid tumor, and what we are seeing is that entire parotid is replaced, but this is something which is the auriculotemporal nerve, which actually circumvent around the mandibular condyle, and actually there is a facial nerve actually that is also going to be involved in this particular aspect. So there are various intercommunication nerves that are involving and leading to the perineal spread. Similarly, submandibular gland and the tongue can involve the lingual nerve if it is near to that site, and actually there could be perineal spread in the parapharyngeal space and then subsequently into the cavernous sinus. If we see, apart from squamous, the histologies which are having very high incidence is the adenoid cystic and the minor cerebral gland tumor, especially the mucoepidermoid. And here they are typically T2 bright, and what we can see on the coronal, there's significant, even though the tumor is not that big size here, but it is having a significant perineal spread because the neurotropic factors that are released by these tumors are very high, and they're having a very high propensity for the perineal spread. This is the mucoepidermoid, again the minor cerebral gland tumor, and actually we can see that there is a perineal spread through the parapharyngeal space and leading to the cavernous sinus. Need to know that not only the malignant conditions can have perineal spread, there are a lot of benign conditions, and here is the juvenile nasopharyngeal angiofibromas, and here we can know that there is a widening of the foramen, there is a brilliant intense enhancement, and there is a bowing of the posterior wall of the maxillary sinus, and again it is going through the inferior orbital fissure and reaching into the cavernous sinus, and this is something which is benign thing that can spread along the foramen. Again, we have seen benign conditions, inflammatory conditions like IgG4 disease, pseudotumor-like conditions, which can also involve bilateral symmetrical involvement of the perineal spread in these locations. knowing to know that this is the facial nerve schwannoma which is having ancient changes, cystic disease, we will not see any cystic changes in case of perennial spread. There will be no primary. It is the only nerve that is going to be involved. And if we see that, we need to rule out whether there is a primary schwannoma that is located. And this is classically dumbbell shape, having cystic changes, enhancement which is having progressive, and there is a scalloping in that foramen ovale region. There are many other radiological mimics of the perennial spread, like if there is a very high venous system, then we can see that there is an asymmetrical venous enhancement that is in the pterygoid venous plexus. There could be a vasa nervosa where the veins can be more, vessels can be more prominent around the nerves, and here the central part of the nerve is not enhancing, that how we can actually differentiate from the perennial spread. There could be normal enhancement of the geniculate region of the facial nerve, but if it is asymmetry and associated with the symptoms, then it could be, we have to rule out infection also if there is no primary. And then there could be incomplete fat saturation, in which we can actually mislabel something as an enhancing. There could be cavernous sinus thrombosis, where we can see that there could be an asymmetrical enhancement. And then there is an invasive fungal sinusitis. We can see there is a lot of necrosis that is actually here, and there is enhancement along the nerve. So all these are actually potential mimics of the perennial spread. Coming to the posterior fossa, where we can have a lot of nerves from 7 to 12. And this is the one nerve which is more commonly associated, and most of these presentations are like polypectomy and other things done by the ENT, and then they are presenting. Here if we see that there is a widening of the stylomastoid foramen, and then till the genicular area that is actually involved. On CT is very difficult to see whether there is any kind of enhancement. We will see that there is a scalloping, but the moment we do an MR, we see that it is having classical features of schwannoma in this particular location. Again, they can have the ancient variants, in which we can see that there could be a lot of cystic changes that can occur, and this is the schwannoma that is extending into the lower branches through the parotid, and we can have that there is a cystic change with fluid fill levels in this particular location. Apart from that, in the internal auditory canal, we can have acoustic schwannomas, in which there could be intracanalicular portion that can enhance in this particular spread. Again, there is no other pathology, so it is only the nerve that is going to be involved. So it is primary, the nerve actually is involved rather than the perennial spread. We can have bilaterality in these, and there can have punctate hemorrhagic foci in these if there is a loose connective tissue in these areas. The main thing is that if we are suspecting about schwannoma, sometimes we can confuse with the very vascular enhancing paragangliomas, and this is the vagal schwannoma, in which we can see that there is a displacement of the vessels, and which is showing homogeneous enhancement, but that is without any phlovoids. If it is without any phlovoids, then it is more likely to be schwannoma, because schwannomas doesn't they have the paucity of the veins, so the gadolinium can pour in, but it will not take the washout. So in the later phases of life, it can have a strong enhancement. Opposite to that, the glomus can have rich venous drainage. So as soon as the contrast is coming into it, it will rapidly wash out, and then it can follow the curve. But at some point of time, they will meet together. If the imaging is delayed, then the schwannoma can mimic like a glomus in this particular aspect, that we need to be careful about it. And this is something, this is a case where it is a parotid tumor which has been operated and then radiated because it was high grade, and this is something which has been labeled as an incidental acoustic schwannoma, which is having some changes of fluid fill level also, which is, though it is very rare, but it was present in this, and 4 years down the line it is destructed everything. And the first thing, when we reviewed the scan again, which has been operated outside, there is a thin linear enhancement along the facial nerve, which is extending from the parotid and actually going into the internal acoustic meatus, and this is leading to the significant destruction. So it is very important to identify the perennial spread. It has been identified earlier. Either the patient might not have undergone surgery, or if it has undergone surgery, at least it has been taken care by the radiation. So this catastrophe can be avoided. So we can have mimicker of the symptoms, in which when there is a central lesions that are there, they can compress the nerve and look like there could be nerve involvement, but it is just the compressive symptoms. In this case, it is a GCT which is expanding and causing compression of the cavernous nerves in the cavernous region. Again, this is a head and neck primary. This is the thyroid CA, which is having since last 3 years, and when the patient presented with the last 15 days with the lateral rectal palsy, and this is because of the clival mat that is occurring in this particular location. So many of these things actually we can get to know from the multidisciplinary team discussion. So it is easier to find out what you are actually suspecting and where exactly the disease is lying, and it's often our job in the perineal spread. Even though such a 4 millimeter size of the tumor, there could be a widespread perineal spread that is reaching into the cavernous sinus. So apart from the extent, we need to mention about the perineal spread because it will change the staging of the patient. And something like this, which looks like bilateral orbits involved, there is intracranial extension, there is a lot of perineal spread. And if we see that, they will respond very beautifully in the lower section. So need not to say that surgery is always an option. There are multiple other options, like in this case, the CTRT has been given depending upon the histology and showing brilliant response. And since last 3 years, the patient is doing very well. So we need to know the histology of these patients, whether the lesions are looking resectable. If the lesions are looking resectable, whether there is a perineal spread, and if there is a perineal spread, how far it is actually spread. And that is the information actually the oncologist want from us. So they need to know what kind of surgery they have to do to achieve the complete resection, or whether they have to cover something under the radiations. So there are some pathologies which can actually have high propensity, like the nut midline carcinoma, which is a variant of squamous and SMARCB1 deficient tumors, which we have reported 32 case series. There is a high chances of the perineal spread in these areas. Coming to that, if we see that spectral CT, which is having polyenergetic beam, subtle mucosal enhancement are actually better appreciated. So probably in future, if we want to pick up on the CT scan itself, whether there is a chance that the nerve is enhancing, probably with the spectral CT we might able to pick it up, because this is going to commence next month. So we will see how it goes about. And then there are new treatments that can be done. In this case, there was a hard pellet tumor, and then there is a perineal spread, and the patient was in very, very painful site. The pain score was 9/10, and then we did a chemical ablation at that particular site, and then we will see that the pain score has dropped down significantly. This is something which can be experimented in various settings. Again, sir has already elucidated about the proton therapy center, in which we need to know that what are the areas that we can actually cover, and whether we can enhance over the photons and do a better care in these, because there is no exit dose, unlike photons where there is an exit dose and there is high chances of complications. This is something, again, it is not a perineal spread, but it is schwannoma, and it is very, very vascular schwannoma. We can see that there are a lot of flow voids that are actually there, and when the surgeons has took, there was a catastrophic bleed in the OT, and then they thought okay, whether we can do actually something about it. Then we did the cryoablation in these settings, and actually the patient was actually doing well, and we can see that there is a large area has been ablated post these cryoablation needles. And we need to interact in a multidisciplinary settings, where we need to participate in the various clinical groups to understand their need and what exactly they mean by the perineal spread, and how far actually they can go about it, whether they can resect till the foramen ovale or the other sites, and that need to be mentioned in these reports. So just to end this thing, why we should care about the perineal spread, because there is an increased chance of tumor recurrence is there. There is a higher morbidity and mortality if we are not able to pick it up, these tumors in early settings, because we have seen that patient has been resected for the buccal CA, and 2 days later they present with the ptosis, and the perineal spread has been missed because there was a skip perineal spread into the cavernous sinus, and the disease is still there. Patient has undergone morbid procedure, and then there is no survival as well. So MR is better than CT in picking up the perineal spread, and the T1 pre-contrast and post-contrast are equally important, and perineal tumor spread does changes the management, and we need to report this. So thank you so much.
Thank you, sir, for the insightful session. Your systematic approach, especially in discussing the differentials and mimickers, provided great clarity and practical insight.